Okay, and then I wanted to make sure that we introduce some of the other folks from the core team, which includes Andrea and Delilah and Sabrina.
Hi, good morning, everyone. My name is Andrea Boichi. She, hers is my pronouns, and I am the Director of Office of Recovery and Resilience. Welcome.
And Delilah?
Good morning, everyone. This is Delilah Morales, and I am your Traditional Health Workgroup Policy Analyst. Welcome, everyone.
Sabrina, and then I'm not sure if Holly is here. Holly, if you are here, I would love for you to introduce yourself as well. Go ahead, Sabrina.
Hello, I am here. I'll be real quick, Sabrina. Holly Heiberg, she, her pronouns. I am the Medicaid Policy Director and many other titles that are on the screen. And I'm so glad we are meeting and we're going to listen and learn a lot from you all.
Thanks for being here, Holly. Hi, everybody. I'm Sabrina, she, hers. It's really nice to meet some of y'all, and I have met some of y'all last week at the Behavioral Health Talent Council reception at the Capitol. That was awesome. It's so nice to put a face to the name. I have also been one of the ones emailing you as well as Delilah. I support two Medicaid behavioral health policy teams, one of which is behavioral health, or excuse me, Medicaid policy teams, one of which is behavioral health. The other is children and families. So nice to be here. I'm one of your supports that you can connect with if you have any questions about the work group.
All right, let's move to the next slide.
And then did we get Delilah?
Yes.
Okay, perfect.
So, like I mentioned, you should be able to see the various representations that are here in this membership for this work group in the scope document as well. And just to give you all a visual of who all are part of this partnership and are going to be working collectively in this work group so that you know where those representations are. Okay, let's move to the next slide. And thank you for going through the slides, Sabrina. I really appreciate it. A quick visual of our agenda today. We're going to have Andrea help all of us collectively do some level setting and speak to the power dynamics and group expectations. And we also have Mitch, who will be speaking to the peer-related policy work that is also happening in the Alcohol and Drug Policy Commission. And then we are going to have our health policy and analytics partner within OHA speak to some of the data on peer services utilization that they have been working on with some in some other spaces. And then we will have some discussion, which are going to be based on the pre-meeting survey that was sent to all of you so that you have a little bit of time before the meeting today to think through them and come prepared to this meeting. And then we're going to speak about the next steps and we will convene for today. All right, next slide, please. Andrea.
Good morning, everyone, again. So first of all, I just want to thank everyone for being here. Today is an important moment as we all come together to discuss peer billing in hospital settings. This conversation is about more than just billing, though. It's about building a system that values every voice and every role in this room. We do have a diverse group here today. We have peers with lived and living experience, providers, CCO representatives, and then also OHA staff. And each of you bring expertise that is very essential to this work. Peers bring hope, trust, and understanding that only lived experience can offer. Providers and administrators bring clinical knowledge, operational insight, and also the ability to shape systems. And when these strengths come together, the impact is very powerful. And it's not just powerful for us, but also for the individuals and families who rely on these services. This work group holds an advisory role. So we're here to make recommendations that will influence policy, guide clinical and peer workforce integration, and build clear billing pathways that support peer work in hospital settings. This is big work, and it requires us to embrace all kinds of lived expertise and professional knowledge. And neither is more important than the other. Both are very critical. And when we understand each other and collaborate, we create something stronger than just any one perspective alone. But before we go ahead and dive in, I do want to acknowledge something very important, that there are power dynamics in this room. Some of us hold institutional authority. Others have expertise that has historically been undervalued in traditional systems. Today, we're just asking everyone to be very mindful of that. So just let's commit to listening for understanding and not just for response. Um, Let us create space where peers feel as valued as providers, and where also providers feel respected for their expertise that they bring. This is about redistributing power and not taking it away from anyone, but by ensuring it is shared in ways that lead to better outcomes for the people that we serve. And so to help us all do that, I'll just go over a few guiding principles for our time together. So we're just asking, let's just respect all voices, right? Because every perspective matters. Um, let's speak from our own experiences. So we'll use I statements when speaking, um, assume positive intent, but it also acknowledge impact if harm does occur. And then just remember that what's shared here stays here unless agreed otherwise. This is also a trauma-informed space. So if at any point you feel that you need a break, please, I can't stress enough, please do whatever you need to care for yourself. We want to make sure that this space is very welcoming um, for everyone. And because the work we do here today is about equity and inclusion as well. It's about recognizing that peer support in hospital settings is not just kind of like a nice to have, right? But it's transformative. Um, Peers help bridge gaps between clinical care and real life recovery. They reduce stigma, improve engagement, and then bring hope at moments when people need it most. And research has shown that when peers are part of the care teams, outcomes really do improve. And that's why this conversation matters. But each of us has influence in the seat that we sit in. But together, we do have the power to shape a system that honors both lived experience and professional expertise. And when we understand each other and work together, we create something stronger than any one perspective alone. So that's the vision for today. So it's collaboration, honesty, respect, and a shared commitment to unity. So once again, I just want to thank everyone for being here and for leaning into this work. So let's get started. Go ahead and hand it back over to Sabrina.
Thank you, Andrea. Next, we have Mitch Dewitt and Will Burkhardt, who will speak to the peer-related policy work that's happening in the ADPC.
Great. Thanks so much. Hey, everyone. My name is Will. I work for the Alcohol and Drug Policy Commission as a research and policy analyst. My focus is on recovery work and recovery policy. A little background. So the ADPC is an independent state agency. It recently completed a comprehensive plan for 2026 to 2030 to increase access to services related to substance use. Yeah, so there are 5 committees at the ADPC: the prevention, treatment, recovery, risk reduction, and youth committees. And so the recovery committee's work includes a strategy to standardize peer recovery support services across systems. And so like this work sits on the recovery committee, but we also acknowledge that, this peer work probably touches all of those 5 committees in one way or another. So I said standardize peer recovery support services. And when we say standardize, we're talking more about the clarification of the roles of peers and communication out to those who provide or use peer services about the role of a peer. So this isn't the ADPC creating new competencies. It's about communication. And so all of this work is to ensure peers' primary duties remain focused on sharing their lived experience and connecting with a client, and that these peers aren't asked to step out of their role. So over the next 2 years, the ADPC Recovery Committee will assess effective peer work at all levels and settings of peer provision. 2026 will be spent on sort of information gathering, collaboration, and prep for a 2027 work group. And then the ADPC plans to develop guidance documents and create a communication plan by the end of 2027. So this is an exciting way to align peer work groups and an opportunity if you want to provide input for those who want to be involved in this ADPC work as we move forward and stay aligned.
Thanks, Will.
Mitch?
Yeah, and this is a fun way to, I think, of being able to see how many parts of our system are intertwined, because even though Will's committee holds the peer and recovery side of this also kind of has a double banded effect within our treatment committee. So for those of you that aren't aware, House Bill 4002, the decriminalization bill, as most people refer to it, also did a bunch of other things. One of those things that it sought to do was increase access to medications for opioid use disorder access. The long version of it, or the short version of explaining all this, is we were asked to write a report documenting what were the barriers and recommendations for increasing MOUD throughout the state, or medications for opioid use disorder, and to implement each of those recommendations where possible. One of the things that emerged super early on was this really kind of scary thing that does happen throughout behavioral health, all of healthcare, which is people do fall through the cracks. And one of these early solutions that emerged was, where could peers be embedded safely, competently, and consistently in order to smooth out those cracks and be able to kind of reduce the amount of folks that fall through those cracks. And because most people would, I guess we would say, like, are entering the system in a more medically fragile place if they're coming from the hospital system, like what a great place to prioritize. So I just want to say that the ADPC treatment committee, in addition to the peer committee, is really standing behind this effort to both kind of see that there are cross-agency alignment, but also that we might be able to help with that alignment across different agencies and even with ourselves where this works, to measure that impact. Because I think this is one of those things that as we shift that policy, it'll be so cool to look back in a year or two and be able to be like, here's the moment when, or if we've made this change, and then like, here was the impact that this had on Oregonians ever. And I think that this is that really fun place of, as this team is working with us all to talk through what this could look like, also like being able to think like, how could we show that it was effective or where it was less effective in order to support those efforts. So just thank you so much, Rusha, and your whole team for spearheading this effort.
I see there's a hand up. Thank you, Mitch.
Hi, good morning. I put my question also in the chat, but I wanted to clarify whether the ADCP will be also addressing billing for peers in different physical health settings outside the hospital, or who that work will fall to.
Rusha, is that something more that you want to answer? So what I'll say is, like, we would love to see this in the settings where this makes sense to do so. I think the more important thing right now is that we implement this well and correctly as this goes forward. And so one of the things that I'll say that that I think that our committee members supported was being able to prioritize this setting, see what goes on, and then how do we move on to the next of those things. But I think Rusha can kind of explain a little bit more of the why, because I think for me, this is one of those like very delicate Tetris pieces in a lot of ways of like being able to say, like, if we tomorrow said peers in all settings, like I can't imagine like the rupture that some people might have stress wise for trying to implement that whole thing. So I guess that would be my take as the person who's more just on the like vision and viewpoint side.
Yes, very similar to what I was going to say as well. It's because there are so many different spaces where this question has come up, and then we want to make sure that we're not doing the same work in multiple places parallelly, and then kind of addressing, prioritizing and addressing each one of those settings as we move forward, knowing that some of the work may happen here, and then eventually some of the work will happen with ADPC, and then some of the work will happen in other groups, including the governor's office has been looking into these issues as well. And I did see Holly come off mute for a second, so I wanted to make sure if there was something you wanted to add there, Holly.
I think you can see we're committed to figuring out how how we're going to really work to integrate peers meaningfully into the systems of care that Medicaid supports. And I want to just acknowledge that we've done a poor job of that over the years. And so I consider this a deep breath and a reset. And yeah, this is the first piece of, I don't play Tetris, but I get the meaning. So this will be the first important step.
Okay, I want to make sure I don't miss any other hands that are up. And if there are questions about, I saw Mitch, you also put in the chat the link to the ADPC plan. We'll make sure to include that in our follow-ups to today's meeting. And if there are questions about ADPC or the work that ADPC is doing and presented on here, would it be accurate to say that folks can reach out to you two, Mitch and Will? All right, great.
Yeah, and our meetings are public, so feel free to drop in as well, but I'll make sure our emails are in the chat.
Awesome, thank you. Okay, let's move to the next slide, Sabrina, thank you. And this is the part where we look into some really exciting data work and analyses that has happened done by our partners at OHA in health policy and analytics.
Hi, everyone. Erin McCauley. I use she, her, hers. I am with the Behavioral Health Policy and Analytics Division, and then I sit in the Office of Health Analytics. And because we love a nested set, I am the Behavioral Health Quality Metrics Manager. So my team supports behavioral health data in a variety of ways. And I have some slides. I think, Sabrina, were you going to screen share for me?
Yes, and I am getting them up right now for you.
And data might be a little bit of a stretch. I think just wanted to share some highlights with folks that have come up in some other spaces as sort of a discussion preemptive as you all head into those discussion spaces for things that we've identified recently and some other workspaces. So yes, Sabrina, just a moment.
I think you have the same issue, Erin, with like the present in Teams. It's a weird feature.
Yeah.
I'm just going to keep it simple and just screen share like this.
Alrighty. So background wise, oh yeah, for some reason we can see your whole thing, but you're in presentation mode.
Oh, that's really weird. Would it be okay like this, Erin?
I think so. Can folks see that okay? Okay, we can move on to the next slide.
Okay.
Alrighty, so background-wise, there is some separate groups happening. As folks know, HR1 is going to have some future and long-term impacts onto folks' ability to access services and how we deliver those services in the future. And so we have started having some conversations in smaller groups to support the work that is happening with the governor's office and the medical advisory group. And so it's been largely kind of called Medicaid Sustainability Work Group. I don't know if we actually have a formal name, but that's what comes to mind for the meeting series that I've been joining. And so within that, we had a smaller subgroup to support behavioral health data exploration. And even then within that, we split up that subgroup into these deep dive groups to support specific areas of exploration as we were having those conversations. And so peer services was identified as a smaller deep dive group. And so just wanted to kind of share some of the highlights that came out of that smaller deep dive group. Next slide. All right, so why peer services? So early on, the peer services CPT code, the billing code, H0038, was identified as something that potentially had a huge cost growth. So there was exponential growth in service utilization of this specific CPT code from 2023 to 2024, and growth in use means increased cost. I also want to flag, though, that that increased cost is pretty nominal. So this code bills in 15-minute increments, lots of 1-hour chunks of time. So 4 15-minute increment claims that are submitted for that 1-hour time period. But that does add up. And we saw just huge growth from 2023 to 2024 of people utilizing that specific peer services code. And so next slide, wanted to do a little bit deeper dive since we saw that big growth. Just some of the things to sort of highlight that stood out to myself and others in that group when we were looking at it. So substance use disorder related diagnoses had the highest peer service utilization in 2023 and 2024. So that kind of aligns with things that we've seen and other efforts that have been stood up in the last 4+ years. And then again, in the first 9 months of 2025, because we have a lag in our claims data of about 4 months, substance use disorder related diagnoses, again, had the highest peer service utilization. So keeping that in mind, that a lot of our folks who are accessing peer services have a primary diagnosis of substance use disorder. Next slide. All right, and so the other piece, another highlight, was that we saw the highest utilization of peer services by Medicaid members who are living in frontier, remote is my preferred terminology, zip codes. So highest utilization, folks who are living in remote Oregon, and then second highest was folks living in rural zip codes here in Oregon. Next slide. Another thing that kind of popped up that we felt like was really interesting were folks who identified in the federal race ethnicity category of American Indian, Indigenous, and Alaskan Native community members had the highest utilization of peer services. That utilization rate for those community members was actually more than 2 times the average number of monthly peer services that the next race ethnicity community had. So they were using peer services exponentially more than some of the other communities in Oregon. Next slide. And my last one. So peer services, specifically the H0038 CPT billing code, was also the second highest user service delivered by culturally and linguistically specific service providers. So out of everyone who's providing CLSS services, peer services was the second highest to be using or delivered by our culturally and linguistically specific service providers in Oregon. And that's my last slide, but just some of those things to kind of highlight. We're seeing lots of growth. We see lots of growth in remote and rural Oregon. We see lots of growth in utilization by folks who have a substance use disorder related diagnoses. And then we're also seeing certain communities who are using peer services more than others. And that we're also using culturally and linguistically specific providers to deliver said peer services. So between all of those things, it felt like there was a lot more for us to explore further. At this point, we're kind of in a holding pattern until we learn what further exploration could look like data-wise, but here to support that in any way we can. I think I also would highlight that data and numbers are also people or representative of people, and there's a lot of things that we can't tell in claims data by lived experience or other experiences that folks are having as they navigate our services and access and what those service outcomes look like. And so keeping that in mind too when we're using data to tell that story. So that's all I got.
Thank you, Erin. I am wondering if it would be useful to give folks just a couple minutes to think through your presentation and see if there are any questions or if there are any slides that anyone would want us to go back to ask questions. Please feel free to ask that as well.
We do have a question from Tammy that says, I don't know if Tammy, you want to come off mute or just want to read it?
Sure. Yeah. Question about looking and subsetting between adult system and pediatrics. So we are able to look by age. The only issue and why we don't typically share is because the subset of pediatrics is 0 to 17 years old is what we typically are looking at. The numbers are so small that we, to present, have to aggregate up to such a degree that you lose a lot of the meaningfulness behind the data. So it is possible, but the numbers are small enough that we have to aggregate to a regional level. So we lose some of the intentionality there.
So can I just ask a follow-up question? So am I understanding that when we think about the data that you just presented, that represents adults and H0038 being coded for adult peer support being provided, not family or youth peer?
I'm sorry, I had a hard time hearing you. I turned up my volume, but can you repeat the first part of your question for me?
Yeah, sorry. I wanted to make sure I was understanding that the data that you presented and the coding to H0038, that really represents adult peers providing services, not family and youth peers. Is that correct?
Not sure. Let me see if, we'll see if I'm understanding the question first, and then if I'm not, feel free to interrupt me. So when we poll, we're not able to identify whether or not the provider who provided the services specifically is a pediatric or adult provider, like if that's their subspecialty. We can see if the individual who received the services fell in a certain age bracket, but that doesn't necessarily indicate provider. So it was anyone who provided peer services using and billing against that code. So there was a combination of all ages that were represented in that subset, but it was not necessarily by provider type. So,
Erin, would it be accurate to say that because you pulled the data from the MMIS system, which is the Medicaid claims system, so at that point, you were looking at the code that was billed, which is the H0038, and then the provider type, which is indicating a peer, and then you're able to filter for the age that they have, that those providers have served, and that's the extent to which you have visibility, whereas any further distinction of exactly what kind of peer, that was not visible to you when you pulled the data. Would that be accurate to say?
yeah, yep. At least in the way that we had originally pulled it. We could do some mapping potentially to see if we could identify who specifically provided services to each individual that had a service, but not something that we had further explored in that group.
Not seeing any other questions in the chat, but are there any other questions for Erin or any other comments or suggestions? Okay, and if not now, always feel free to reach out later as well. And thank you so much, Erin, for your presentation. Okay, and then we can move to the next agenda topic, where we will have a discussion on the questions that we had shared with you all in advance to look at and think through your comments and in general, if you wanted to bring anything up specific in these areas. So you all had received a survey, and many of you have responded to the survey, which was very helpful for us to kind of organize the conversation today some more. And I'm going to ask Nathan to help guide the group through this discussion here.
Thank you, Risha. So hopefully everyone had a chance to look at our pre-meeting survey and collect your thoughts. And yeah, we're going to take some time to share our thoughts, to speak out, to listen to others and see what thought that inspires. So invite everyone to really open up and share what we have, what we're all thinking about. And I think we are ready for the next slide. Is that right? Yes. Okay. So give the group a chance to think about. We on the state side will be taking good notes. The meeting's also recorded, so we can capture thoughts afterward too with more detail. But I'd like to open up discussion about the number one here, and if folks could think about how do your current programs intersect with hospitals or with inpatient? Where are those touch points that peers are really able to enter into the care team with hospital patients, and let's capture some of the good work that is where we are intersecting. Yeah, Raven.
Quick question. Are you speaking in the ways of like advocacy and peers? For the like billing, like what are you?
Yeah. So I think we're open at this stage really to any ways that you're interacting. I think some of the folks in the call are in much more of an advocacy kind of a role. We may have some folks on the call who are in the direct service kind of a role where peers are involved in the treatments.
Okay, so I can, from my perspective, from what you're saying,
Yeah.
My understanding is like when my interaction, so I'm what you call an all around. I have several degrees or several certifications and specialties, and I interact within multiple communities, but within mine, majorly. When you're interacting as such, is whether it be in advocacy, whether it be in peer support, it's either taking a serious thing or the stigmas behind it. So when you're searching for sustainable ways and alignment of context of like what goes on in those spaces, the barriers you encounter are greatly so the stigmas behind why are you here? Why do you need somebody to support you? What about you needs this support or this peer support for us to even consider it? Those bring in alignment to things like CHWs, peer support specialists, peer wellness specialists, and why they are so important to many diverse communities. So I think in that one, that's one of the things you're gonna challenge or deal with barriers is those stigmas and overall projections. And then billing limitations, as we all know, like I said, they just passed something not too long ago. I'm sorry, it's not off the top of my head where you can't bill for certain things. So there was a certification, it was a peer certification that Medicaid no longer allows you to bill for without a higher certification. Um, and it stops those who needs those supports. It really does put it, put a hold on those people who really can't speak for themselves because now they have nobody to speak for them.
Yeah, thank you. I really appreciate your input. Can I ask some follow-up? Your hands back up. Please continue.
Oh no, we're fine. Sorry.
Okay. Okay. If I may, some follow-up questions. It sounds like that some of the barriers are on the are peers able to work with the hospital teams and the hospital staff, and some of the barriers are on maybe the hospital teams and hospital staffs are ready to go, and but there's payment challenges, and so they can't fund and support the work. So yeah, thank you for sharing. Thank you for sharing that. Let's see. I see next hand up.
Hi, good morning.
Deanna. Yeah, Deanna, if you want to go. Sorry,
Hi.
I was having a hard time finding your name.
No worries. Hi, I'm Diana Smith. I'm here representing the Oregon Perinatal Collaborative as the clinical lead for our statewide perinatal substance use disorder work. And I also have worked with Project Nurture. So we have nurture programs around the state in rural Oregon and in the Portland metro region at an integrated into a number of physical health systems, including Providence, Kaiser, Legacy, OHSU, Adventist Health, and at the nurture sites in rural Oregon. And the perinatal peers are working, some of them are directly employed by the hospital system, some are employed by peer organizations and contracted with the hospital system. There are benefits and challenges to each of the models, and certainly there needs to be some more support and guidance for physical health systems around integration, like appropriate supervision being in place, support structures, and education around how to integrate with the medical team, and the unique elements of like interfacing with a medical team in the hospital environment. Billing is a major limitation because there is such a significant need for perinatal peers, given the impact of substance use disorder and untreated mental health on our pregnant and postpartum Oregonians, contributing to our mortality. The peers that are working in this domain have like untenable caseloads. The work is really intensive, focusing on engagement early in pregnancy, but really intensively around the time of the birth, helping folks navigate the child welfare system, figuring out entry to treatment and coordination from physical health into behavioral health and SUD systems. And at times, our peers are also working in other traditional health worker capacities. They have expertise in training and certification, often as doulas. And so they hold this sort of joint knowledge and expertise, which also impacts their work hours. And for sustainability of the workforce, we need to be able to bill for their services in physical health settings so that we can have funding in those settings to set up the correct work environment and grow the workforce there. Thank you.
Yeah, thank you. Let's see. Jenny, I got your name right?
Oh, depending on the platform, where's the unmute button? Close. It's Janie,
Janie.
and glad to be here. Thank you. So we have at the peer company several hospital programs. We launched our first peer support in a hospital setting around, well, a little over 10 years ago. And we have programs in emergency departments, inpatient settings. We've had them integrated into the peer/doula roles with Project Nurture at times. And so some of those barriers we've encountered are the preparation of hospital staff, so that they have a shared understanding of the peer role, and the peer supports have an understanding of who's who in the programs they're integrated with. And one of the areas or departments that was the most challenging is the emergency department, just because of the sheer amount of hospital staff that rotate in and out. But preparation is key. And then the shared expectations, having some continuity about what is expected of the peer support and that communication flow. We have typically been a vendor and have also supported some direct hires within hospital systems, and have seen the challenges and the benefits of both. And then scope drift, just so challenging to navigate in every peer program, but one especially that is embedded or spends most of the day in a medical setting, and bringing it back to that peer role. And then the challenge with billable hour versus peer work. And I think someone, Raven, mentioned it earlier. How do you not make it about that billable hour and more about, are we doing authentic peer support, and how does that get funded through Medicaid billing? Thanks.
Thank you.
I see two more hands up, but my
Actually,
apologies.
Nathan, can I just wanted to uplift something that was put in the chat. Is that all right? It's a good time
Yes,
for that.
please.
Okay.
Yeah.
So around 5 minutes ago, Sarah Bovee from Project Nurture had said that their program intersects with the hospital and inpatient setting by providing in-person support through MOUD, inductions for pregnant persons throughout their entire hospital stay, including birth support, system navigation, and onto the floors that their infants are cared for. Sarah, did you want to say anything else in addition to your comment?
No, thank you. Can you hear me?
Yeah,
Yes.
perfectly.
Yeah, no, thank you. But I'm grateful to be here. Thanks for uplifting that.
Thank you, Sarah. Another comment, second comment, was from Tammy from Oregon Family Support Network. Family support specialists often engage in the hospital setting when parents arrive at the ER with the child experiencing mental health or behavioral health challenges, and parents do not have another option to support their child. So the ER becomes a housing location for short-term, and often parents' only option is to take their child or youth home because there are no beds available or providers don't have any other options. This is a place that our peers often intersect with parents who don't know what else to do or aren't able to navigate system level expectations. Thank you, Tammy. Very true story that I've seen back when I did street medicine, so definitely resonate. Tammy, did you want to say anything else about your comment that you put in the chat?
No, I'm good. Thanks. Sorry, I couldn't get off the mute.
That's okay. Okay, thank you, Tammy.
I think we're on to Elding. I'm not sure if I'm getting your name right.
Yeah, hi everybody. My name is Eberhard. Last name is Elfing.
Last
Can you
name.
hear me okay?
Yes.
Okay. Thank you. I first just wanted to say that I cannot better verbalize what Diana and Janie have already said about the obstacles and barriers for peers with integrating into those new programs or settings like hospital settings. Myself, I'm coming from the primary care setting, and one of the kind of integral services that I provide are often for people who are leaving inpatient settings or hospital settings. So I work a lot with discharge planners and do a lot of health literacy and health systems navigation. I also, and that sometimes also connects to people who have been previously incarcerated and educating them on the correct systems to use after having spent so much time within the jail system, as far as differentiating between primary care, urgent care, and emergency department utilization. And I just wanted to bring that kind of entry point and exit point of the hospital setting into the conversation as well. Because those, like I said, those barriers that Diana and Janie brought up are present across the board, I think.
Thank you. Melissa.
Hi, good morning, everybody. And that was perfect timing because I had a conflict at 10 o'clock. So I was afraid I wouldn't be able to say anything before I had to jump off to join my other meeting. I'm Melissa Eckstein. I know quite a few people on the call this morning, and what I wanted to share, and I'm coming from viewpoint of, this is my 37th year in behavioral health. I have a parent with severe and persistent mental illness, which, as my mother is aging, has presented a lot of different challenges and being a caregiver, not in the same state as my parents are. So I have a lot of different things as I'm listening to everybody and trying to help formulate. This is a huge topic, I think, for this group to tackle and where we're going to go. I am coming from a systems perspective, and I know there's other representation from our legacy team on this call. And my viewpoint right now is representing the health system and the hospital system in this discussion. And I'm really excited that we're at this place where we're getting to talk about what reimbursement looks like, because I think the biggest thing that has not given consistent importance and understanding to what our peer mentors play in our system of care is the reimbursement mechanism. And so what that has done in the time that I've been here in Oregon and that I've been at Legacy is that it's put the hospitals in the situation of having to figure out, how to incorporate and to pay for that, which has played out in a lot of different ways. And so what I'm really hoping is that we're able to come out of this with a way to sustain keeping this important piece of our care model across the state, and really being able to permanently cement how our peer mentors are used in the health systems. Because right now, I think that we have pockets of success with that. And I think that we have pockets that are not sustainable and have really, I think, diminished the importance of, that piece of our care model over time. So I want to bring forward that I think, that the limitations of how we're able to get reimbursed for those services is probably the crux of what's kind of over time, eroded, I think, a lot of relationships and just how, we're able to have a good, solid foundation of because this is very important. I know, just speaking for Unity, that we had a really defined program that I think there was a lot of value, and it caused a lot of rift across our entire team when we had to dismantle that because it just wasn't, sustainable for us to continue. So now we're trying to rebuild that and, looking at that. So thanks for letting me share this morning.
Thank you so much. Let's move on to Judith.
Hi, so my name is Jude Leahy. I work for OHA and have been doing peer work since the 1990s. But at OHA, one of the projects I work on is a project called Prime Plus, which is peer recovery initiated in medical establishments, plus infectious disease screening and linkage to care and treatment. And this project stood up in 2020, right at the beginning of the COVID epidemic, and one of the goals was to work in hospitals for peer-based services. And I want to really elevate everything that Janie was talking about in terms of our experience of trying to work. This is not a Medicaid reimbursed model because Medicaid wasn't reimbursing the peer work. This is funded under the State Opioid Response Initiative. And we have a strong evaluation that shows what peers who are supported to do this work are able to accomplish. But I did want to bring up, I think, as we're talking about this in this space, is that I hope that we can have a discussion that the outcomes here are peers that are anchored in community agencies that are able to bill Medicaid versus larger institutions. And I know that might not be a popular opinion with some folks, but when we think about the whole person and what community-based peer programs are able to do versus a program that's anchored in a particular place. So if you stop going to that clinic, you lose your peer, or if you're not in this place, you lose your peer. I think that a lot of the changes we've seen in participants who later became peers, who later went on to become managers, who later went on, is that the wrapping of peer programming. I just hope it doesn't get lost in this larger institutional discussion. It has been a challenge to have peers get into the emergency departments and in hospital programs. I know it is difficult to sustain, and I'm glad we are having this discussion. I just really hope that at the end we're talking about peer programs that are based in community that are able to bill Medicaid. Thank you.
Thank you so much. I was taking a note for myself. Let's hear from Julie.
Hi, I just wanted to also throw in a little bit about my experience of working in a medical setting for the last 10 years, and having peer support outside of that setting. And I just feel like the lived experience being our profession can lead to we're already getting the secondary trauma, and we we often face burnout and high turnover because of not having the specialized training and the specialized support that I believe that would be so beneficial for us. Compassion fatigue, all the different kinds of fatigue set in that cause these types of burnouts and secondary traumatic experiences. And I believe that an approach that can be very helpful is to move away from clinical supervision or outside peer support supervision that isn't directly uh, doesn't have the experience that we have facing what we face inside of the medical setting. So, supervision models that have the experience, I believe, because in my experience with my supervision, they meant well, but they didn't understand what I was going through. And so my supervision, my support, I had to piece it together, and it hasn't ever been appropriate, I guess is the word, because I feel like if we had something specialized and formal where there were peers who have been through what we've been through, and there was someone championing that specialized supervision and a place where peers can go and get peer supervision, that would be more sustainable for us in the long term.
Yeah, wonderful. Thank you. Thank you for that input. So before we go on to the second half of the slide around innovations and sustainability and desired outcomes, I want to pull on a couple of threads from some things that I heard. So as far as in the hospital setting, the groups of patients, the groups of people that I heard talked about, folks that are having babies, maternity kind of care. That's a group that we are reaching, or some of the groups here are reaching and are really benefiting from peer work. And I heard folks talk about being able to be there in the ER and help families and support families that are in that circumstance. Are there any other models that or groups of patients that we're reaching, or the group thinks we could reach or should be reaching, or is that really where we're focused, at least as far as we're aware? Deanna.
Hi, Diana Smith. There are also peers on addiction medicine consult teams in the hospital who are working with inpatients and working to coordinate transitions out of the hospital back into the community and do some community follow-up.
Thank you. Kristen.
Hi, yeah. Diana, you're correct. There is. I'm Kristen. I'm with Providence. We do have peers pretty much embedded throughout our hospitals. We have them on inpatient, on medical, on inpatient psych, in our emergency departments. And it's pretty robust kind of in Portland, but and not as robust in our outside hospitals in the smaller communities, but there is peer support in every single one of them. So and some people might be familiar with Becky Wilkinson, who will also be on this work group, who can really speak to kind of the operations and how we feel. And her team has created a pretty sustainable model in terms of support for those peers, education to our medical providers. So she'll be here at the next meeting. So I'm hoping, like your question about kind of what's worked well, what's sustained the peers. I mean, we don't have a funding model beyond grants at this point. So I'm interested in the billing piece, though I will say I do get concerned that that could turn people into what can I bill as opposed to what is the work. And that makes me a little bit nervous. So I'll stop there. Thanks.
Yeah, thank you. Judith.
I would say there are also, we did talk about the substance use disorder peers, or peers that respond when someone has a substance use related hospitalization that are as they're leaving. But for the model that we work, the Prime Plus model, we developed a set of core principles, and we actually have our own clinical supervision. We monitor whether or not our sites, Janie can talk to this because she actually supports our sites that get peer specific and peer led clinical support, as well as the we just have we have a training curricula for onboarding. We have ongoing learning collaboratives. We offer CMEs. I can share with you the report. I think as people were speaking, particularly the person that was sharing about not being able to access clinical support that person that was useful. I think that is something, like you see the peers at the top, there is an iceberg underneath of supports that keep folks able to do this work over time, including taking breaks. But I did also want to bring up, and I know this is not the place, but I do want to say for folks that don't fund peer programs, peers make the highest peer program that we have, or they're paying a little bit less than $26 an hour. And so we're asking a whole lot of folks for very little funding. And I just wanted to kind of put that out here too, as we're talking about reimbursement, making sure that we're reimbursing and increasing living wages for the peers. But I think that there are databases where you can capture stuff. There's clinical support models that have been developed. We're definitely not starting from scratch. And as I see folks on this call, we have a lot of people that have been doing work to support peers in a siloed way that hopefully this group can bring together.
Yeah, thank you so much. I'm going to pull on a few more threads before I move on from who we're reaching in the hospitals. Any last thoughts on that? Okay. When I was listening to folks talk about the barriers, I heard people talking about the expectations on peers and the supervision that sometimes is well-meaning but doesn't necessarily understand the work or the workforce. The scope drift, and I wondered if anyone had any additional thoughts in that area of challenges. Yes, Janie.
Yeah, thank you. I call it the phenomenon of lived experience and plugging peer in front of a variety of roles, including the doula role. And just from the experience that we've seen at the peer company, it's really challenging to blend two very specific roles and have it be both. And which minute, which hour, which day am I either or? And I'll use the doula work as an example, and this may be the first some of the folks are hearing it, but it really is a specialized doula role rather than a peer support and doula role, in my opinion. The specialization is the lived experience. And so it seems we and the system have plugged peer in front of case manager or in front of navigator or in front of doula when it's the valued lived experience, but it's not the peer support role in and of itself anymore. And so I just want to name that as a challenge we've seen over the years to try and reconcile both under one umbrella of a job.
Yeah, thank you. Any other thoughts on that front? I'll probably move us to one more thread that I wanted to pull on. I heard quite a bit about payment. One theme I heard is the grant-based payments or the not sustainable funding models, right? The hospitals have a grant, they're able to do it for a while, and then they're not. And that creates uncertainty within a system, and it also means that we're very intermittent or it's different across the state, right? Some areas have a funding source, they're able to go forward. In other regions, that hasn't come together. So I don't know if anyone has any additional thoughts around the sustainability and those aspects. We've covered it pretty well. Yes, Deanna.
I'll just say that the one model that we've had some success with outside of grant type funding is an alternative payment contract with Care Oregon for some supplemental services, so a per member per month. The challenge has been that the reimbursement does not align with the value of the service, and the payment then often is split between a behavioral health organization and the physical health organization, which makes reimbursement complicated and is just with one single payer. We've not been able to expand it throughout our CCO region or around the state.
Thank you.
But it does have some value in that it's not a direct fee for service model that requires peers to be documenting like every 15-minute increment and dropping charges and those things. So in some ways, I think it's a good approach for reimbursement for the robust support services that they're offering if the payment was higher and universal.
Thank you. I heard some discussion about community agency versus and a model that is hospital employed peers, and some pros and cons under sort of both of those settings. I think there's also some models where the community agency that's contracted with the hospital, that any billing to insurance is managed by the hospital versus community-based agency directly billing insurance. I wonder if there are any additional thoughts on around that theme. Right. I think my last thread that I wanted to pull on from the discussion so far was around the supervision of peers and the need to have a supervisor who understands the peer work. And I wonder if there is any additional input folks have or experiences folks have on that theme.
Nathan, sorry, I didn't raise my hand, but I wanted to uplift something that came into the chat.
Yeah.
From Mitch from ADPC on sustainability. So one sustainability thing that they're thinking about, knowing that many recovery organizations plan for in their budgets, peer hiring. This is peer hiring is a very equitable process, which includes onboarding and retention costs that may be different or greater due to needing to help learn some skills that might not have been necessary in a previous career. A lot of peers are coming to the work as a second career. Non-peer organizations may struggle here for sustainment as a result, like losing staff to recovery challenges, onboarding, etc. So hospitals may see a quote unquote sticker shock. Mitch, do you have anything else that you want to tackle onto that comment? Thank you for sharing.
Not really. I just wanted, like I said, I'm taking a little bit of step back and living in the chat, but it's something that I know that I think I could kind of see there being two camps of like folks in peer orgs who are like, we could third party contract, and then there are probably some hospital systems that are like, we'll direct hire, not understanding that. So like I think that guidance could save some trouble in the end.
Thank you.
Thank you. Julie.
I think Diana was before me.
Okay, Diana.
Well, my hand was actually kind of a clarifying question for you, Julie, around Nate's question, which is, are you asking for supervision from someone who also has experience working in the medical setting and hospital setting, who's also a peer, or what would the optimal?
I just feel like we stay peers all I mean, there's just this, there's no tier system. There's no way to work up. And I see people that don't know what I do trying to support me. I'm a specialized doula. I'm a perinatal peer. There's nobody that really knows what it is that I do. And I think that the solution would be a tier system so peers can move up and support each other. And to have something in place where we're not just staying at the same level and getting that little increment, pay increment each year for our, what we get, the little raise we get each year, but actually for the work that we've done and for our, the experience that we're gaining, we could have a tier system to support the peers that are coming in. I think that people that have done what I've done are the best support that I could get. And I have tried to get support from organizations that do this work, even inside hospitals. And it's not the same. I haven't gotten the support that I needed unless it's with somebody that's doing the work that I'm doing. And I don't know what the solution is, but I do know that we need a tier system and we need to be able to advance in our careers. And that would be a solution.
Thank you.
I heard, I did see the term or terms a couple times in the surveys, like career ladder, lack of career ladder, like Craig had echoed in the chat, is an ongoing challenge or lack of one. And I also heard, I remember a comment from someone, I don't remember who said that some peers they worked with or had employed had become managers. I was wondering who that was and if you can speak to how that has happened and how they've succeeded in that.
Yeah, I was going to say this is Jude from OHA, and I work on Prime Plus. I think so. The way our program approaches peer work, and I think this is something that Mitch kind of touched on as well, is that for some people, they get into peer work and it is where they are going to stay and they are going to swim and that's where they want to be. There are other people that come into peer work and they do the work and then, through the experience of doing the work, they emerge as, they want to do other things. And we feel in our model that it is our goal to help people achieve what they want to do, just like the way that our peers interact with their peers. I'm here to help you. I don't always have the answer, but we can figure stuff out together. What do you want? What do you need help from today? And so peers have, just like all of us, have life goals. And so it's more than an employment situation. It's people, in recovery, recovering out loud and in the workplace. And Julie, I just want to say thank you so much for everything that you're sharing. I feel, I guess, I started as a peer decades ago, and I just feel like it is an honor to be involved with this work. It is an honor to walk beside people. It is heartbreaking to me when I hear about people not being supported to do their work. I feel like it's just more than an employment situation. We are asking people to walk into fire with someone else after just getting out and being safe themselves. And we're asking them to do it over and over and over again. I'm sorry, I get really passionate about this. But it's more than an employment thing. This is the right thing. And if we can figure out how to bill for the right thing, then we can help people show up in communities where maybe at some point they're showing up in places where before they were either clients or they were inmates or they were, and I use the word inmate because that's how people are treated, not how I view them. And I don't know. Anyway, that's kind of how our model has evolved over the last, 6 years. But I think it's more than just a job, and I don't know where to put that in this space, because we're talking about billing, right? And we do track. We have people tracking. There are databases you can track this stuff, but at the end of the day, you've got people showing up for other people to give them a handout and a hand up and to walk beside them, because many of these people didn't have that when they recovered and when they were in the hospital. And some of the stories that people share are, I've joined this work to be the person that I needed at my darkest moments. And so it's kind of how we celebrate. We get sad when people leave because you have to get over this. You're going to get your workforce stabilized, because you're not, because people are growing and we're helping people grow. And then they go somewhere else and they grow more and they grow more. And the people that come behind them get into the positions that they were in, and those people grow. So I think you have to think about this workforce differently than we think about other workforces, but that's just my passion and not necessarily the logical component of what fits into a billing line.
Thank you so much. It's absolutely relevant. I think the billing, the payment has to be supportive of the truth, right? And so we need to unearth the truth and really understand the model. So thank you. Let's see, Charity?
Thank you. My name is Charity Anderson. I am the THW liaison with Gobi, and I just briefly wanted to comment on the supervision piece. So throughout Eastern Oregon, the large majority of our peers are employed within CMHPs. So obviously the community mental health programs are clinical based. The fact that the supervisors themselves, come into the role as a clinical supervisor to supervise clinicians, but then they're also being asked to supervise peers, and they remain in a clinical role, but they're also not required, but needed to have that understanding of what peers do, but they don't necessarily have the support and the place to go to get that training on what it takes to supervise peers. And so you've got clinical supervisors that are supervising peers in a clinical role. Then you've got organizations that aren't necessarily, they don't have the understanding to support those supervisors, to support those peers. So, I mean, to me, this is a big concern. And then, definitely what we're talking about today with, hospitals. It's something that I just really wanted to comment on and throw it out there. Especially for Eastern Oregon, we just don't have the supervisors themselves. They just don't have the skills needed or the understanding to truly support peers and really recognize the roles that peers play throughout Eastern Oregon.
Thank you. I think I'll transition the discussion to focus on the second half of this slide, particularly the number 4 around the desired outcomes. So I'd like to open up the discussion space for what's that bright future that you all see that we should be aiming for, that we should be driving toward. Never heard.
Yeah, maybe this is kind of like an obvious thing to say, but along the trend of supervisors, clinical supervisors needing a lot of support and education about what peer services are, something that I've encountered is my supervisors and like upper level management do not know how to implement billing as like a new program, as a new peer program. So making sure that supervisors have the tools and guidance to create a new billing program is also extremely important and very relevant for the conversation. Just wanted to really pinpoint it down.
Thank you. I think our prompt is also asking for questions, policy, things that tools, guidance, things that we on the state side might try to pull together to bring for next meeting. So welcome any thoughts around that as far as desired outcomes as well.
I had a question. I can see in the chat, I think it's Sabrina is asking about are the majority of peer supervisors actually clinical supervisors? And I think that would be something to do a survey on. They don't have to be, but there are in the OARs a set number of hours that are supervision requirements for peers every 2 weeks. So I don't know if everyone in this group knows what all the OARs are related to peer work. I just wanted to ask that out loud of the group, because we certainly could pull together what's the requirement and then ask agencies what they actually do. In my experience, at least in our program, 100% of agencies are doing the minimum, and most agencies are doing a lot more.
Nathan, I also see a comment from Diana around perinatal peers have developed a community of practice, and I was wondering if they could provide a little bit more information about that, because that sounds like a resource I'm not aware of. If anyone else is not aware of, would be very helpful information.
I can speak to it, but I would defer to Julie or Sarah.
At the health share level, we have peer leadership now, and well, for a time we've contracted, and all the peers through Project Nurture and peer doulas are able to meet together and work together to build out this peer role, and with support and resources and community. I think that we also have decided recently that because there are other perinatal peers or specialty doulas that are interested in this work, that we would like to open it up. If we're going to be doing learning circles or whatever, so that we can grow the workforce and provide that structure and support for whoever else is interested in having that community. But Sarah, if you want to speak to it too, I don't know if I'm leaving anything out, but it's just getting started. It feels like a breath of fresh air to have somewhere to go and with the people that are doing this work and hear similar and be able to connect after doing this for so long and not having that. It is such a breath of fresh air. And the way that we are able to communicate with each other, back each other up, and just provide a space outside of the clinical setting, because we are all peers at heart. And there's a difference between being a peer in the world and being a peer in the clinical setting. So being able to go and be in that community has been very empowering. And we do want to open it up for other people who are interested in harm reduction, peer work, or doula work, excuse me, and for peers that are doing that work.
I guess I would just add that currently it's like a traditional health worker community of practice, and it's for all the Project Nurture sites, but also partners Nurture Oregon. I think that we're going to be having our first combined community of practice really soon.
Thank you. That was really helpful. And when you said you're opening it up, does that mean if others outside of HealthShare are interested, they can reach out to you?
So I think the idea is if we're going to be doing trainings or any kind of learning circles, that we would open it up to doulas that are interested in doing harm reduction doula work, so that they can have a community as well.
Great. Thank you. Thank you. I just wanted to make sure others are aware of this.
We'll make sure to
great
we'll make sure to get the word out when we get to that point. It's just in the planning stages at this point.
Excellent. Thank you.
Lucia, it feels like we're kind of wrapping up on the discussion for these questions. So.
Yeah, I was just actually doing a quick check to see if there are any hands we're missing. Oh, I do see Diana's hand up. And I'm sorry, am I pronouncing your name correctly? Is it Diana or Diana?
Diana.
Okay, thank you.
Thank you. Yeah. We haven't named explicitly the role that the COA plays as a barrier for billing. So I just want to make sure that is highlighted. Since there are many organizations now who employ peers that do not have a COA, and the administrative rules and the ORSs require the COA for reimbursement. And I'm curious from an OHA perspective, like what the path forward is, like if a decision is made to allow for billing and reimbursement for peers in physical health settings, whether the rules need to be amended or whether we're working towards writing something separate that applies specifically to physical health, and just sort of the logistics of getting from here to there, if that's the decision that's made.
Yeah, thank you for bringing that up. And I can speak a little bit to that and welcome my other OHA colleagues to chime in here. But this, what initially what we had identified, that there is confusion that exists because of the way the OARs exist right now. And as we looked into where we need to make some revisions to our OARs, that's where the discussion evolved into the need for a work group like this, so we can very precisely and very accurately identify through recommendations with our partners outside of OHA who are representing these very specific settings, that what is the most appropriate way to revise our rules based on the recommendations that we get from our provider partners. And that includes peers and individuals and families who receive and use peer services. So this is part of that whole work, how the rules will be revised to make it most appropriate for Oregonians.
I'll just say no one likes the rules. Everybody finds them overly vague. So as we form recommendations, whichever direction we head, we're committed to trying to be precise enough that everybody has clarity, like exactly what you should do. So yeah, and we didn't want to presume anything. We wanted to listen to everybody.
Okay, don't see any other hands up. Checking the chat real quick. Oh, thank you, and Andrea, for putting the acronym for OARs. Okay. It looks like there are no other questions that are coming to folks' mind right now. But like I said before, this is not your only opportunity to share your comments or your suggestions or questions with us. Feel free to reach out to us even outside this meeting. And as you know, we have a series of this meeting that we have scheduled. Our goal is that in April of 2026, we are able to pull together some solid recommendations from this work group. And a lot of that has to do with the timings around how there is impact of the recommendations, and then the influence it has on how we revise our administrative rules and CCO contracts and all of those things, which has led us to set April of this year as our goal. So there are some information here you're able to see, which is the survey that we have shared. If you have not responded to the survey already, please do so by Wednesday, February 25th, which is tomorrow. And our next meeting is in March, and we will be reaching out to fix the date on that one with all of you. And we will also share notes from today, from our meeting today, and any other follow-up items that we needed to take back and respond back to you. We will share those via email with all of you who attended today.
Rusha, I want to make work not hard on this scrappy little team that's come together and focused on this. And at the same time, I just really want to check in. Can everybody meet that survey deadline for tomorrow by 6? Is that going to be okay? Okay.
We have a lot of responses already, so thank you for that. All right, and if there are no other last minute thoughts or suggestions, I think we can take back 15 minutes of our time and go move, do anything else that helps us feel ready for the rest of the day. And again, we thank you so much for partnering with us and sticking with us as we took the time to plan it, and coming to this meeting and being part of this work group and really helping us think through how the experience is on the ground for those who are providing the services and for those who are using the services and need the services. Thank you so much for all you do, and we will see you in March.
Thank you. Bye.